So what are re-emerging diseases, you may ask? They are diseases that once were major health problems, either globally or in a particular country, and then declined dramatically, but are again becoming health problems for a significant proportion of the population. Today we'll be reporting about a certain type of re-emerging disease called diphtheria. For the viewers watching that are unaware of what diphtheria is, here is a small clip to explain.
Diphtheria. What is it? Diphtheria is an infectious disease caused by the toxin-producing strains of the bacterium called Corynebacterium diphtheria. The toxins released by the bacterium cause the disease itself, which affects the mucous membrane of the upper respiratory tract. This would include, but is not limited to, your throat and upper airways. The common symptoms include sore throat, mild fever, swelling glands, and malaise. In young children, diphtheria can progress to acute respiratory distress, upper airway obstruction, and asphyxia. You can be infected by inhaling respiratory droplets of an infected person, or in rare cases, if you come into contact with articles soiled with their secretions, you can develop the disease. Fortunately, diphtheria can be prevented through immunization, as vaccines are available.
Welcome back to our roundtable discussion about diphtheria. Today in our studio we have myself, Gerline, Tricia, Kara, and Sukman.
So continuing from the video, when a proportion of immunized individuals of a population drops below a specific threshold, the pathogen that was described in the video can be introduced into the population, leading to an outbreak. The toxigenic strain, Clostridium bacterium diphtheria, is the most prevalent bacterium microorganism that is responsible for the disease.
Yeah, and if we look at the history of diphtheria, in 1959, the routine childhood vaccination was initiated with a pertussis diphtheria toxoid vaccine, a tetanus diphtheria toxoids vaccine, and somewhat later, an improved diphtheria tetanus toxoids pertussis vaccine in order to prevent the progression of this disease. The status of immunity to diphtheria was monitored using the Schick test, and more recently, selectively by serology, as you all saw the importance of controlling an epidemic of this disease. In 1989, the World Health Organization, WHO, had a meeting that was also facilitated to endorse a recommendation that planned for full control of diphtheria throughout Europe by 1995.
And then back in 1985, there was a universal immunization program which was implemented in India and included recommendations from WHO that newborns should receive 5 doses of a diphtheria toxoid containing vaccine. So the first 3 doses would be administered at 6, 10, and 14 weeks of age, the 4th at 16 to 24 months, and the 5th at 5 to 6 years. This hasn't been effective in some places though, as seen with the reemergence of diphtheria occurring in relation to the inadequate vaccinations of certain populations. Due to the resurgence of cases in India, specifically Kerala, for example, as part of a national program, laboratory-supported vaccine-preventable diseases surveillance was initiated in April 2015, with support from the World Health Organization National Polio Surveillance Project.
So what is happening now?
So there are many unreported cases in the world, but from what is reported, we know that the prevalence of diphtheria cases in Southeast Asia, particularly in India, are quite high. There's also varied vaccine schedules depending on the country. So to ensure not only children, but adults are fully immunized, Singapore recently implemented an initiative to increase adult vaccinations. However, in America, there can be as few as 2 cases per year after vaccinations.
So you mentioned vaccination schedules.
Yeah, so WHO recommends a series of 3 doses of the primary vaccination followed by 3 booster doses. So generally you'd be given the 3 primary doses with a minimum interval of 4 weeks in between, while the booster doses are given later in life, so after 12 months of age, and in between these booster shots, there's a minimum of 4 years interval between each. So the trend you would see among some countries is that countries are offering the primary series or boosters only before the age of 6. So thus they're having a higher proportion of unvaccinated cases as compared to those offering adult boosters later in life.
So can you explain the vaccines that are available?
Yeah, so the diphtheria vaccine is given to treat the toxins that are released by the bacterium to render them non-toxic. But at the same time, it should be able to maintain the capability of eliciting an immune response when the vaccine is taken.
Okay, so a DTaP, that contains the diphtheria and tetanus toxoids and a acellular pertussis component, which is cost saving through its combination, as seen in the US, where $4.2 billion was saved within the healthcare system. And this is usually given to infants, so those between 6 weeks and 6 years of age. DT, however, contains only the diphtheria and tetanus toxoids, so again, they're given to infants and children aged 6 weeks to 6 years, but these specific individuals have a contradiction to the pertussis component.
Tdap contains tetanus and diphtheria toxoids with acellular pertussis component. It is given to adolescents and adults, usually as a single dose, with the exception of pregnant women who would receive it during each pregnancy. So compared to DTaP, Tdap has a reduced diphtheria and pertussis dose since it boosts the immunity that wanes from the 4 to 6 age vaccines. Thus, it is referred to as the booster shot.
Right, and then TD would have the tetanus and diphtheria toxoids present, and they're given to children and adults ages 7 years and older. So when you compare that to the DTaP formulation, this one has a small d because it contains a much smaller quantity of the diphtheria toxoid.
So if we look at statistics from 2000 to 2015, the highest rates of diphtheria can be seen in India, Nigeria, Russia, Ukraine, Nepal, Indonesia, Afghanistan, and the Philippines. Diphtheria is also most common amongst poor urban children in temperate climates. Since 3 doses are given at separate intervals, follow-up can be hard. Thus, 50% of infants receive 3 doses of DTaP and 70% only receive 1 dose.
Based on past immunization records, majority of the patients, which was 54%, were unimmunized and only 19% of the patients were adequately immunized.
So this could be maybe due to the ignorance about vaccination and false beliefs, or maybe the lack of healthcare facilities, or even socioeconomic status.
But what about developed countries?
Well, in countries with sporadic incidence rates, like developed countries, the cases are evenly distributed over adults that are unvaccinated, partially vaccinated, or even fully vaccinated people.
Exactly, and countries that have lower incidence rate utilize the primary vaccination schedules, plus more booster shots. As for the economic impact seen today, global DTP coverage is estimated to exceed 80%. That is because DTP is a mandatory component of most immunization programs.
And vaccines constitute an extremely cost-effective method for reducing the burden of disease. Combined vaccines lead to a lower cost for vaccination programs than separate vaccinations.
So we really need to take steps to increase our immunization, and this can include immunization barriers at parental, household, community, service delivery, and country levels. So now that we know more about vaccine, we should really implement vaccination. So back to you, John, at the studio.